Hello and welcome to our next live event tonight. It's good to be back here, and thank you already for joining our event tonight. And well, we have another interesting topic to discuss today. And with us, we have tonight Dr. Raul Olivares. Hi, Dr. Raul. Hope you can hear me well.
Hi. Yeah, hear you very well. It's happy. It's funny to hear you saying tonight when we have such a bright sun here, as you can see my back.
I am very happy to hear that. I definitely think in Barcelona it's a beautiful weather right
Yeah,
now,
yeah,
right?
almost
Okay.
summer.
Exactly. So that's good to hear. That's really, really nice. Okay. And well, as you can see, our topic tonight is recurrent pregnancy loss. And well, we will start with the most common questions that we receive on this particular topic. And then we will go for your questions. All you need to do is just type them in the chat section. And Dr. Raul will definitely advise you and provide you some details. So don't hesitate and just simply type them all in. And well, I just wanted to remind everyone that we are here every single day. And as you know, we are here just to support you throughout this whole uh, well, no more lockdown because we are able to get out a bit more, but still we are all waiting for the borders to be opened, and so that you will be able to start with your treatments. So the clinics are reopening, so fingers crossed it will be possible. And of course, just wanted to remind everyone once again that those events are brought to you thanks to our ambassadors and partners as well. You can see them all right here. So again, thank you so much. And well, that would be it from me for now. Dr. Raul, are you ready to begin?
Yeah, of course. Okay,
Perfect.
so I really I don't know how I dare to accept this issue because recurrent pregnancy loss is probably one of the most difficult issues to deal with in IVF. Most of the time, because we lack of the information that we need to know, that we need to find out the real reason of the miscarriages. It's very difficult to know what happens once we have transferred the embryo. We almost lose control of what happens inside. So if from the different reasons that we have or the different reasons that can cause a miscarriage, getting the exact information and identify a single factor becomes a nightmare sometimes. Um, Also, we have another problem is that even the definition of a recurrent pregnancy loss is controversial. I mean, there are countries or trends, or I don't know how to say that would consider a recurrent pregnancy loss when you've had three miscarriages in a row. Others, like, for example, as we consider that once a patient has had two miscarriages, we should consider her as a patient with a recurrent pregnancy loss. In some cases, we have patients who have miscarriages and then a successful pregnancy and then again miscarriages. So the definition and how or when should we recommend going for tests, exams, and to identify factors that can cause a miscarriage is also difficult. So that's probably the introduction. Is a very tough issue because of the lack of information that most of the time we have. The tests are controversial. Some of them are not conclusive, and more often than when we thought, there are kind of mixed factors, and then we have to take into account all of them before moving forward with a new treatment.
Okay.
So, Caroline, if you want to start with a question.
Yes, thank you so much for that introduction. And yes, it is time for those most common questions. And let's go to the very first one. Should patients be treated once we found what would be the problem, or is it worth to carry out all the studies and only start once we've discarded all causes of recurrent pregnancy loss?
Well, this is a really a tricky question. The fact is that usually patients who go through a recurrent pregnancy loss have such a big emotional burden that when they decide to come to you to see if there is anything that we can do, they want to avoid at I would say 150% sure, uh, any further miscarriages. As I've said, also there are a lot of cases in which there are mixed factors, probably not factors that are 100% the reason of the problem. But as I say, sometimes zero point 0.1 plus zero point 0.1 plus zero point 0.1 makes a 0.5, 0.6, or a higher risk of having a miscarriage. Because one of the things that we are going to see in this kind of patients is that we can only talk about risks. There's no way we can reassure them that everything is okay. There is no way we can guarantee that this is the main problem that has caused the miscarriage, because most of the time we are not going to know why they have miscarriage. So our opinion is that once you identify a patient that can be classified into this group of recurrent pregnancy loss, it's usually better to carry out all the tests. At least probably there are some more sophisticated or controversial that could be just postponed, but at least all the standard ones that we have that we know for sure that are useful in this kind of patients should be done, because we don't want to transfer healthy embryo genetically tested into a patient that may have a clotting issue to end up in a new miscarriage. These kind of embryos become very valuable, and we cannot forget that in some cases we may be successful without any kind of treatment, without any IVF. So in some cases, applying a correct treatment may be enough. But if we have to go through IVF, we must be as sure as possible that once we transfer the embryo, this is going to be not just a pregnancy. Most of the time, these patients have got pregnant several times. We need to be sure that this is going to be, or we need to be sure, I wish I could say that. We need to be as sure as possible that this is going to be an ongoing pregnancy, because these are patients that don't want to get pregnant. These are patients that want to have a baby because they can get pregnant on their own most of the time.
Okay, thank you so much for explaining this first question. Next one is up right here. Is it worth treating all patients starting an as is they were potential cases, or RPL? This is using steroids, heparin, aspirin as standard therapies in the first treatment.
Well, let me send the logical conclusion to my former answer. No, I mean, if these embryos are so valuable, and so why don't we just cover all the different possibilities? The thing is that I personally do not recommend to do that. In the end, we have to be, or we have to work as doctors. So the first thing that we need to do in the first round of IVF is to try to identify, because the anamnesis, the questions, the clinical the dialogue between the patient and the doctors keeps being the main tool to identify risks, problems, and then we can later recommend tests or treatments to solve those problems. So in this kind of cases, we need to do a really long questionnaire, ask of about many different things, and only if we identify there could be any factor, any risk, then we can add them. On top of that, and we may discuss this afterwards, because I'm pretty sure that there are going to be some questions about the use of steroids, immunoglobulins, and immunology in general. We do not recommend steroids, probably in very, very exceptional circumstances, because they have known drawbacks and potential side effects in patients and in pregnancies. Heparin and aspirin, at least they don't have side effects, but I think that they should be recommended only in cases in which we think that they are going to be useful. So probably the first thing that we need to do, unless the patient comes to our clinic because she has a recurrent natural miscarriages, if we are going to do an IVF, we don't need to apply all these treatments, wait for the patients to become candidates to these treatments, because this is not the medicine, or this is, at least I don't think that this is how medicine should be done in this scenario.
Okay, perfect. Thank you so much for explaining this question. And do intravenous immunoglobulins or intralipids help in cases of RPL?
Well, that's a question that could be, I mean, that the answer could be long enough to have a whole seminar about them, you know. And my short answer would be no at all. Okay, and basically the thing is that these kind of treatments are supposed to fix problems that are based on all theories that we now know that are not true. And the thing is that for many years, there was a concept which was called immunological tolerance, in which it was supposed that the woman has to accept the baby, assuming that half of the genetic stuff of that baby was not the mother's genetic stuff. So there would be kind of a rejection. And it was thought that this rejection was mediated by cells that were in the endometrium. The most famous cells could be the natural killers, NK, but also lymphocytes, Th1, Th2, the red TMP. I mean, there are a lot of tests that were developed on assuming that there was something inside of the uterus that could attack and kill the embryo. We now know that this is not true at all. I mean, there are natural killers in the endometrium. There must be natural killers in the endometrium. There must be Th1 in the endometrium, and the level should be really higher than the Th2. So the thing is that these kind of cells, especially the natural killers, are not cytotoxics. I mean, they don't attack, they don't kill cells except in very exceptional circumstances. So they don't behave at all as the natural killers in blood, which are the ones that are usually tested. So there is no correlation between what happens in the bloodstream and the endometrium. In fact, the natural killers in the endometrium are supposed to help the embryo implant. So if somehow we want to reduce their levels, we may be impairing the implantation. This is why we don't recommend steroids. On top of that, immunoglobulins are very, very expensive. There are a lot of reviews, what we call Cochrane reviews, which are people who are specifically investing time on studying all the different articles published across the world and compare the results to try to gather as many patients as possible to see if there is any real evidence of that. And there is no evidence so far that immunoglobulins may help to reduce the risk of a recurrent pregnancy loss. And the same happens with intralipids, and both treatments may have severe side effects. Intralipids are made of soja, so there could be people who is allergic to the soja, may have really severe reactions against them. Immunoglobulins are biological product that can transmit, you know, they are obtained from other people, so there are prions and other things that could be transmitted. There could be also, they could be really very bad tolerated. So I don't think that there is any justification, any reason nowadays to use any of these two treatments in cases of recurrent pregnancy loss.
Excellent. Thank you so much for yet another explanation with the details. Excellent. Thank you. How can we be sure that there are no genetic issues in the oocytes or the sperm?
Well, the fact is that the main reason if we take into account the different factors that may increase the risk of miscarriage, genetics are by far the most important thing. The thing is that it is very difficult to study because we would have to take the embryo and that it has been miscarriage and then test it as if we did an amniocentesis or something like that. So it's really difficult to know the exact incidence of genetic issues in the embryos. But I would say that probably 70% of the miscarriages are due to genetic problems, at least, if not more. So the thing is that these genetic problems can either come from the egg or from the sperm, but sometimes they can come even from the same embryo. Um, Probably the most common reason to have genetic problems in the embryo is the genetic abnormalities in the eggs, which is something that is age related. So it means that as women get older, there is a higher risk of having genetic problems just because the eggs are as old as the woman. You know that the woman is born with a fixed number of eggs. And men produce new sperm every day. So it seems a bit different in the sense the age is not such a relevant issue in men, at least in terms of higher risk of miscarriage. So, as I've said, most of the time, the genetic issues are because there is something wrong in the egg or the sperm. Though, as I've said, especially in the initial stages where the embryo is doing a lot of cell divisions, there could be an error in this cell division process that could be inherited in all the cells that come from this line. And in the end, may be an important issue that may make the embryo stop the development just because of a genetic problem. In oocytes, it's very, very difficult to check the genetics. The thing is that the only way we can obtain oocytes is doing an IVF. And doing an IVF just to pick up the eggs and see if they are normal or not is worthless, because if we have the eggs, what we have to do is create embryos. In the sperm, it's not so difficult. There are different, at least two different studies that can be done. One is called the FISH, which stands for fluorescence in situ hybridization. And then we can also do a study called a meiotic study on the sperm. And these two tests are designed in a way that they are going to check if the percentage of sperm that carries genetic abnormalities is normal or is higher compared to the normal population. And it is important to know that these genetic issues are much more common in males who have a male factor, especially a low count in the spermiogram, but can also be a problem in patients who have a completely normal spermiogram. And in our opinion, the male factor is normally not considered when we are, as long as the man has a normal karyotype. I mean, they have been tested for chromosomes and the chromosomes are okay, but no, sorry, I wanted to say that as long as if the karyotype is abnormal, then the male factor is considered to play a role in the miscarriages. But if the karyotype comes out normal and the sperm is okay, usually no one checks the other aspects of the male factor that can also be relevant in terms of increasing the miscarriage rate. And these two tests that are done on the semen, the FISH and the meiotic studies, would allow us to know if there is any kind of higher genetic risk if we use that sperm. Okay? So if we want to study the sperm, we can use FISH or a meiotic study. If we want to use the oocytes, if we want to check the oocytes, the only way is to do an IVF, obtain the embryos, and carry out a pre-implantational genetic diagnosis on those embryos. If you have previously tested the sperm and you know that the sperm is okay, any or most of the issues that you find in the embryos are going to come from the egg. So this is kind of an indirect way of knowing the genetic quality of the eggs, but you need to first check the sperm to see if there is any problem in that.
Perfect. Thank you so much once again for so many useful details. Okay, next question is there anything patients can do to reduce the risk of miscarriage? Rest, take progesterone, improve the diet, etc.?
It's a pity, but I honestly think that patients can do very little. Okay, I don't mean that if you just do a lot of exercise or if you have a very stressful life, you cannot have a miscarriage. But recurrent miscarriages mean that there is something really important inside, you know, and this is probably not related to your quality of life unless you've been really exposed to toxins or things like that. In terms of, the progesterone is one of the most common things that we have been doing for years and years. When someone has a miscarriage, once you get pregnant, start taking the progesterone to support. But the fact is that luteal deficiency, which means that the progesterone levels are low, it is not so common, especially in cases of natural recurrent miscarriages. Another thing is patients who go through IVF, which in some cases could be good to increase the progesterone levels. With regards to resting, my feeling is that it's only useful in cases in which the patient is having kind of a threat of miscarriage, if they have some light bleeding, or if you see something wrong in the scan, which looks like there is an hematoma or something like that. But having a rest is not going to prevent you. For many years, there was something called lower tender care, which was supposed to improve the results of the patient. So there was the theory that if you do more scans, if you see the patient more often, if the patient feels that you are taking better care of her than any other patient because of her condition, the results are going to be better. And unfortunately, this is not like that. We know now that this kind of love tender care does not improve the ongoing pregnancy rate. With regards to the diet, there is only one thing that for sure is related with a higher risk of miscarriages, which is obesity. Okay, obesity, because of all the endocrine abnormalities that the obesity causes, impairs the implantation and increases the miscarriage rate. So in some cases, it would be really worth to lose weight before getting pregnant, because this is going to reduce the risk. The only problem with this kind of approach is that sometimes patients may have other more important factors that may increase the miscarriage rate, like age, and sometimes the time that you need to reduce the weight is something that patients cannot afford because they are 40 and they cannot spend 1.5 years losing weight. In this kind of cases, what we recommend is to do an IVF, to get the oocyte, create the embryos, if it's necessary, because as I've said before, we prefer to discard all kind of problems that can increase the miscarriage rate, carry out a pre-implantational genetic diagnosis to confirm that those embryos are genetically normal, and then leave them frozen until the patient is ready for the transfer. And then once we have the embryos are not going to become older. They are going to have exactly the same quality. So the patient can invest 6 months, 9 months, 1 year, and lose the weight and return to a normal body mass index, or at least to a body mass index that is not associated with such a high risk of miscarriage.
All right, perfect. Thank you so much. Once again, now it will be our last question when it comes to those most common ones, and then it will be time for your questions. How useful is checking thrombophiles or antiphospholipid
Lipid antibodies.
antibodies in cases of RPL?
Well, in my opinion, this is really, really useful because it's probably one of the few conditions that we are sure that are related to a higher risk of miscarriage. There are different problems, but they cause the same problem inside of the woman's body. The thrombophilies are conditions in which the coagulation does not work as expected, either because there are abnormal levels, usually deficiencies or low levels of some proteins, or because there are mutations in some coagulation factors, the most common are factor 2, factor 5, which may increase the risk of having clotting issues in the surface between the placenta and the uterus. And this is the main reason of why they are related to recurrent miscarriages or sometimes obstetric complications like eclampsias and preeclampsias later on pregnancy, because the surface that is between the placenta and the uterus has this kind of local thrombosis that at some point makes creates problems to supply all the things that the embryo needs or the fetus needs to grow. The antiphospholipid antibodies are antibodies that attack specific substances that are in the surface of the placenta, but they cause exactly the same problem, local thrombosis, and also lead to the same problems that with the thrombophilias. They have short time effects like miscarriages and long time effects like preeclampsias or fetal deaths in the second or third trimester of pregnancies. So the only issue is that with regards to thrombophilias is that with the standard tests, that are those tests that we have been doing since the mid-90s, we check for Leiden, for which is the mutation of the factor 5, for the mutation of the factor 2, for, as I've said, protein C and S deficiencies and things like that. We are only covering up to 25% of the thrombophilias. We now know more mutations that can also. So in some cases, it is worth to do another test that we have, which is called thromboencode, that checks for different mutations that are not tested in the standard treatments, like factor 12, factor 13, other mutations of the factor 5, because in these cases, there might be also another problem, another thrombophilia that cannot be so easily detected. The thing is that if you think that there could be this problem, sometimes despite getting normal results in both tests, we may still consider giving aspirin or heparin, because as I've said, we know more and more about these kind of things, and we cannot discard that in a couple of years we may be able to identify another mutation that is also related, like it has happened recently with the factor 13, which has shown to be very relevant in terms of really good implantation. The only difference between having a really, or being able to identify if any of these tests is abnormal, or when we give heparin or aspirin in, let's say, an empirical way without having a real evidence, is that these kind of problems, as I've said, can, thrombophilias and the antiphospholipid syndrome can also produce problems later in pregnancy. So in these cases, the treatments, heparin and aspirin, should be taken throughout all the pregnancy, not just the first 3 months, the whole pregnancy, and even a couple of months after delivery, because there could be embolias and things like that. So it could be useful, not just because it would let us know if these are the reasons of the miscarriage, but also because could help us prevent some complications during the pregnancy.
Perfect. Thank you so much for so many details once again, and for answering those most common questions. And now it is time for your questions. There are plenty of questions already. So let's get to them. Dr. Raul, are you ready for the questions from the patients?
Yep, ready.
Perfect. Let's go ahead with them then. How do you feel about prednisolone and Clexone protocols? I have had 3 transfers with yourself, 1 failed and 2 losses, and not sure what else we can try.
As I've said, sometimes it's very, very difficult, and prednisolone, as I've said, is something that I really don't believe, unless there is some kind of autoimmune disorder, an already known autoimmune disorder in patients, and in a very selected group of patients. The main reason is that it is a drug that is not free of risks for the babies. The steroids are classified as a potential dangerous for the pregnancy, and also because in some cases we may create a problem that is not there. As I've explained at the very beginning, all kind of steroids are supposed to reduce those cells that are working in the endometrium and that the embryo needs to have a correct implantation. So we have to be very careful about how we use them. In the very small percentage of cases that we use them, we just give a very low doses and only around the day of the embryo transfer, because the way of or what we want from the prednisolone is, or the steroids, is to make sure that the implantation takes place really correctly. So once the embryo has implanted, we prefer to stop them. Clexane, which is heparin, is completely different. I mean, the first thing is that it has no drawback. It has not really relevant side effects. So we have a standard protocol which that in cases in which there is a recurrent pregnancy loss, we recommend taking Clexane 440 milligrams a day. Okay. As I've said, if there is no evidence of any clotting problem for the first 3 months of pregnancy, if there is any evidence of thrombophilia, antiphospholipid syndrome, then we usually work coordinated with an hematologist that is going to check if the levels, if the doses are enough, and how it's going to be taken during the whole pregnancy. I've got cases in which Clexane at the usual protocol, 40 milligrams, is not enough. I mean, I've got patients in which they have been on doses as high as 100 milligrams a day, which is really huge doses. But in these cases are usually hematologists who recommend these doses. We are not used to work with this drug and such a high levels. Apart from these kind of things, of course, we need. I would love to have more information about, which are the different aspects. If the sperm has been tested, as I've said before, if there is any other thing in the uterus, fibroids or an abnormal shape, I mean anatomical issues that may also increase the miscarriage. So that's the only thing I can say. Just focusing on prednisolone, I usually do not recommend it. And Clexane, yes, at the standard dose of 40 milligrams a day.
Perfect. Thank you so much for your recommendation to the question and your question too. And now let's take a look for what conditions are steroids recommended. You have.
Yeah, well, I was sure that it was going to be probably the most the most frequent question. As I've said, according to our standards, we only recommend steroids in patients who have an already known autoimmune disorder, and in cases that have tried to get pregnant and have kept having miscarriages. That there was another factor that makes me believe that steroids is not a good option is that there was a study that was carried out in Italy, if I'm not wrong, that showed that there were patients who had receptors to the steroids in the endometrium. And when those receptors were activated, the implantation rates were really poorer. So it was suggested that this mechanism or these receptors could be related to those patients that may have poorer implantation rates when they are stressed. That when someone is stressed, produce high levels of steroids. And if those patients have these receptors, then the steroids may have a negative impact. So there was, and I remember an American doctor, that was also with me listening to this communication, to this speech, that then asked the doctor, all the time that we are giving steroids, are we causing a problem? And the doctor basically said, according to the data I've presented, yes, because we have no way of currently identify the patients who have this receptor. It was an experimental work. But if this is true, the steroids can only cause problems, and it's going to be very helpful, and are going to be helpful in very, very few cases.
Perfect. Thank you so much once again. And now there's another question up here. So I had one miscarriage at about 6 weeks without reproductive assistance at 40, then later tried 3 IVF from egg donor, which resulted in 1 pregnancy, which ended in chemical miscarriage just before 6 weeks. Would this be a case to do further tests or to handle differently?
Okay. Well, this is something that there is a lot of confusion with that, because people usually talk about 3 IVFs, and probably this patient meant 3 transfers. For us, an IVF, it means a full treatment in which you have to include all the fresh and frozen embryos. And sometimes I have patients say, no, I've been through 3 IVFs and they have only had 1 egg donation and or then 2 transfers of frozen embryos, but obtained from the same donor. So it's a 1 cycle. I'm going to try to answer in both the scenarios. I mean, if you've really been through 3 complete full cycles of egg donor with 3 different donors, and the only thing that you've got is biochemical miscarriages, you have to test the sperm. The oocytes are not going to be the problem. You can have bad luck with 1 donor in 1 treatment, but having bad luck with 3 different donors is very, very, very unlikely. So we have to focus. Okay, because sometimes this leads to confusion, and sometimes I have the information and say, okay, you've been through 3 different donors. Well, basically, in any case, I'm going to finish the answer. I mean, if you try with different donors and you have negative, you have to focus on those things that has been in common between the different cycles. This is the sperm and the uterus, and it's usually much easier and cheaper checking the sperm to see, as I've said before, doing a FISH or doing a meiotic study to see if the genetic, if the percentage of a sperm carrying genetic issues is normal or not. And if it is normal, then you can focus on checking if there is anything wrong on the uterus or in the woman's body. If we are just talking about 1 cycle, the first thing that I have to say is that even the best donor can have a poor cycle. And having a poor cycle does not necessarily mean that the eggs are of bad quality. It means that there are higher risk of having genetic issues, but 1 cycle is not enough to be sure that there is or how would I say that? 1 cycle or an egg donor, let's say that an egg donor, using an egg donor does not guarantee that the eggs are going to be of good quality. Assuming that you've had transfers of blastocysts, day 5, not day 3, then of course, in this case, you've had 2 miscarriages. The main difference is that probably the first one was due to your age at 40, and because you were 40, and now if the donor was a young girl, it looks, though we cannot completely discard egg problems, it looks very unlikely. Probably in your case, what I would suggest is going through the different tests that I've explained, thrombophilies, antiphospholipid syndrome. Why not a FISH to confirm that the sperm is okay before moving forward? And then if everything is okay, go for another treatment. And sometimes in patients that have their own cycles, okay, so that they are not menopausal and they still ovulate, and they have been through different treatments using an hormone replacement therapy, so using estrogens and using progesterone, either pills or patches. One thing that we have observed that in some cases could increase the ongoing rate is working with the natural cycle. So when we have to transfer the frozen embryos, we don't use Proginova or any other estrogen, and we recommend a natural cycle in which we check how the follicle grows, and when the follicle is around 16, 17 millimeters, we trigger ovulation, we add some progesterone, and then we transfer the embryo 5 days after the ovulation, if we have worked with blastocysts, of course. And sometimes, because there are some studies, it's still controversial, but there are some studies that have suggested that the natural cycle, whenever it's possible, could have they have a similar implantation rates, but the ongoing pregnancy rate seems to be slightly better. The hormones, the HRT, is a standard procedure, and well, we assume that in most cases it works very well, but when it does not work, considering a natural cycle can improve. So as I've said, thrombophilias, antiphospholipid syndrome, why not checking the sperm and doing a FISH, at least to be sure that if there is any other problem, it is not going to come from the male side. And if you've been using hormonal replacement therapies and you still have your period and your cycles, consider a natural cycle if you still have some frozen embryos.
There's a follow-up question from the very same patient. So would trying another egg donor make sense since it never took from 5 good quality embryos after considering the other recommendations you have mentioned?
Yeah, but we need to carry out some tests before that. Okay, it will depend. As I've said, checking in depth the quality of the sperm, and not the spermiogram, but the genetic of the sperms may make sense. That will depend a lot on whether we eventually can identify any factor that can explain your negative miscarriages or not. And depending on what we got from this test, we will be able to let you know, to tell you if it's worth trying again or not. Most of the time, it is, because even, as I've said, even the best egg donation cycle is not going to offer you 100% success rate. Okay, an accumulated pregnancy rate of a good egg donation cycle is going to be 85%. So there's still a 15% of patients that are going to get pregnant in the second treatment without having any abnormal tests. So that's how a statistic works. And because that, I'm sure that there are a lot of factors that we are currently unable to know or to identify, that just keep trying you could fix them if you just keep trying. So as I've said, carry out those tests that have not been done, especially checking the sperm. And if the sperm is okay and everything is okay, well, you can try again with another donor, probably adding aspirin, heparin, and see, and you may get pregnant. I mean,
Perfect. Thank you so much once again. And actually, there's a additional information from the previous patient. This question, okay? So if you could perhaps take a look. So four full ICSI cycles and only one embryo on day 5, transferred fresh each time, retroverted uterus, otherwise normal hysteroscopy, sperm, DNA fragmentation normal, low morphology.
If you could just let me know your age, that would be great, because that's, I mean,
Yes.
my answer will be completely different if you are 31 or if you are 42.
Oh, okay. Yes. Sorry. Just give me a second. I lost the question, I'm afraid. Here it is. Sorry. 41. Yeah. And I've had 3-4 rounds of ICSI, 3 miscarriages. Okay.
Yeah.
At 13 weeks, we had products tested and it was karyotype normal, and male had the hereditary thrombophilia screen and all normal. Me and my partner's karyotype are normal.
Well, this is another common issue, that sometimes we tend to think that all miscarriages are due to the same problem. And it makes sense, I mean, in terms of statistics, as an event happens once and again, it is usually because there is a common common problem in the back. I mean, probably most of them caused by the same issue. But we cannot discard that sometimes in patients who have a problem, there might be other issues that can also lead to a miscarriage. For example, in cases in which we have identified that there is a genetic problem, either because the karyotype was abnormal or either because the fish was abnormal, we have done an IVF, we have genetically tested the embryo, so we have done an IVF and a PGS, a pre-implantational genetic screening. We have transferred a genetically normal embryo and the patient has had a miscarriage. The thing is that we are never going to completely avoid the miscarriages. As I've said before, sometimes the miscarriages are due to problems that appear in the embryo, and some of them are absolutely unavoidable. Problems with the heart, problems with an abnormal development. There are always going to be problems of implantation that we are not going to be able to fix because the dialogue between the placenta and the endometrium is barely known. We know very few things. We have a lot of information, but we have not yet connect all this information to know why a genetically normal embryo coming from a fertility proven girl does not implant, because I've got cases of patients who have decided to carry out a PGS in an egg donation cycle without having any problem in the sperm, and we have transferred genetically normal embryos, and they have ended up in miscarriages. So the fact that the embryo was a male is very significant, because sometimes when the embryo is checked and the karyotype is of a woman, it's difficult to know if the karyotype belongs to the mother or belongs to the fetus. But if it's a male, it should be the karyotype of the fetus. With regards to the thrombophilias, again, remember that the standard tests, which include protein S, protein Z, factor 2, factor 5, only cover 25% of the thrombophilias available. So you could either consider checking other factors like 12, 13, or the mutations of 5 to see if there is anything wrong at that site, or once you get pregnant, then consider adding aspirin or heparin as a standard, as the standard doses during the first 3 months of pregnancy. One very important thing about aspirin: it's very common to see patients that start aspirin when they start the treatment, or when they are about to have the transfer, or even when they are pregnant. That's completely useless. Aspirin, in order to have a full anticoagulant effect, you need to start it 4 weeks before the embryo transfer. So if you have not started at the mid of the previous cycle of your stimulation, you are not going to get a full anticoagulant effect. The same with the heparin. The heparin works much faster. We usually start the heparin when the patient starts the treatment to prepare either the IVF or the hormonal replacement therapy in intonation, okay? Because with these 2 weeks, we have enough time. And should be started at the very beginning, because the use of hormones, either because you have been stimulated or you are adding estrogens to the therapy, may launch some very subtle coagulation issues at the endometrium that, if we start the heparin too late, may not have time enough to fix them. So aspirin 4 weeks before the embryo transfer, heparin at the beginning of the treatment, regardless of being IVF or not. In your case, of course, one extra factor, 41. So the fact that the pregnancy that reaches week 13 hadn't any genetical issue does not mean that the other two could have a problem. So probably, if you consider a new round of IVF, my recommendation would be to check the sperm first to see if there is anything else on the sperm side, and then consider IVF PGS, pre-implantational genetic screen, because this is the only way in which we are going to know the real genetic quality of the embryos. And also it's going to help us to see if the genetic has played a relevant role in your miscarriages. I mean, if you test 5 embryos and 4 are abnormal, probably these miscarriages at 5 and 7 weeks had also some kind of genetic issues. If you test 5 embryos and 4 are normal, then before transferring these embryos, we would have to very closely focus on other aspects that may also... you only ever get 1 embryo in each cycle. Well, then I wouldn't recommend you what we call an embryo banking, which is something that sometimes can be done, which is going through different rounds of IVF to accumulate embryos and then carry out a single PGS. My recommendation in your case is that if you check the sperm and the sperm is normal, probably my recommendation would be egg donation, because age is going to make everything getting worse, you know, and of course, completing the screening of the thrombophilias and antiphospholipid syndrome if you have not had it done yet.
Okay, perfect. Thank you so much for your question and your answer to that.
Just one thing that I would like to point out. I'm pretty sure of that, but I just want to tell you, sure. It's very, very difficult to in this. I mean, recurrent pregnancy loss are very, very complicated cases. So I just want to make sure that patients understand that with the limited amount of information that I have, it's very, very difficult to give a correct answer. I mean, we need to evaluate many different things in these cases and discard many problems to make sure that we are giving the right answer.
Of course, yes. Perfect. Thank you so much once again. Next question is up right here. Have you used intrauterine GCSF to this kind of cases? Any experience?
Granulocyte colony stimulation factors. That's because I'm sure that people that is not going to know what GCSF stands for. Well, this is something that has been quite popular in America, but it was mostly used to increase the implantation rates, in cases of recurrent implantation failures. I know that there is an American group that is very keen of using this, but the person who had the first study which suggested that was useful carried out a second study, much bigger, with more people, and concluded that was useless. That these kind of colony stimulation factors did not improve implantation. So nowadays, it's not recommended in the standard practice because there is no evidence that it helps. And as I've said, if it could be useful, it could be in cases of recurrent implantation failures, not on cases of recurrent pregnancy losses. I'm not aware of any study that has used this to fix this problem.
Okay, thank you. Understood. And any experience of the use of antioxidants?
Well, antioxidants also are still very popular, but the relevance that they play, especially on the women's side, is very, very, very low. Antioxidants have proved to improve the spermiogram, okay, but in those patients who had a better spermiogram, they have not led to more babies, which is in the end what we want. So it has improved the quality, the overall quality of the spermiogram, but this has not translated into more babies. Okay, it's true that these studies are still going on, and I don't know if any particular one, coenzyme Q10, DHA. But as far as I know, and I didn't really very exhaustive research 3-4 months ago, because I prepared a lecture about diet and IVF, so I read a lot. There is no evidence that antioxidants improve the quality of the eggs, and no evidence that antioxidants improve the implantation rates. So with regards, I know that DHA has been suggested to improve even the genetics of the eggs, but that's very controversial, and only very small studies with a very low quality of evidence have suggested this. So so far, no evidence that antioxidants may improve the genetics or the quality of the eggs in a way that they can reduce the higher miscarriage rate.
Okay, perfect. Thank you once again. There's another question on GCF. So do you use it by high natural killers in the uterus?
No, not because of the GCSF, because I don't think that there is no correlation between the levels of natural killers and the outcome of the IVF. There's, if I'm not wrong, there are only 2 big studies that have tested that, and the results of those studies is that there is no evidence that there is a correlation between the levels of natural killers and the outcome of the IVF. And as I've said, natural killers are essential for a good implantation. So I can understand this kind of obsession to try to lower them, because in the end, around the implantation is when you can find the higher levels of natural killers. So it should be like that. And if we reduce those natural killers, the only thing that we are going to do is make it more difficult for the embryo to implant in the correct way. The natural killers, being really precise, regulate how deep the embryo implants. If we don't have natural killers, we may have a very superficial implantation that is going to end up in a miscarriage or preeclampsias or eclampsias, or they may get implanted too deep, reaching the muscle of the uterus, and this is going to lead to also to placental problems like acretism, which is also another complication. So let the natural killers do their work.
Okay, excellent. Thank you so much again for that. And next question is, I have had 4 miscarriages in the last 4 years. My TSH is 3.3. Do you think this could be the issue? Should I get a more thorough check of my thyroid before I think about starting IVF egg donor treatment?
Okay, if I can just can ask for something, please. If you could add the age to your questions. I know, as I've said, it's very difficult sometimes because there's a lot of factors involved, but the age is the critical one, you know. I assume that because you are considering egg donation, probably you are over 40, but the having 4 miscarriages at 31 is a completely different scenario than having 4 miscarriages at 45. Okay, thank you. But if you just could add, that would be really helpful in order to give you an answer. I assume that you had your IVF or that you've had 4 natural miscarriages in your last 4 years, or you may have had them after IVF, you know. But that means that you started having miscarriages when you were 41. So probably in your case, the main factor is your age. Yes, natural. Okay, thank you. The age, I mean, that's the thing. That said, the TSH is also slightly controversial because we usually consider that normal levels should be below 4. But in patients who are trying to get pregnant, there were some studies that suggested that if the TSH was higher than 2.5, there could be some problems at the initial stages of the pregnancy, because at these stages, because of the number of cell divisions that the embryo is going to do, there is a very high demand of thyroxine. And those patients that have TSHs between 2.5 and 4 may be in this kind of border situation, that once they need to produce this extra thyroxine to help the embryo evolve, they may have problems. This is why when we have TSHs higher than 2.5, we usually recommend patients visiting the endocrinologist to decide if it's worth taking low doses of thyroxine just to keep the thyroid relaxed in the initial stages. But in your case, no, probably you don't need to do any further testing of the thyroid. And because of your age, yes, I think that your age is enough to explain your miscarriages. And if you've got pregnant 4 times at this age, if you go for an egg donation, your pregnancy rate is going to be absolutely gorgeous because you implant very well. So once we change the eggs, your pregnancy rate should be over 60-65% with 1 embryo.
Okay, perfect. Thank you once again for this. Next question is right here. Can you explain to us what exactly is a missed miscarriage?
I'm not sure what this does mean. I mean, we have 3 different types of miscarriage. Okay, we have the biochemical miscarriages, which is when someone gets pregnant but has the miscarriage before we can do any kind of test to clinically confirm that she is pregnant. So that means that she has a positive, and for a few days later she starts bleeding and have a miscarriage, and the patient has not had time to have time to go to the doctor. This is what we call a biochemical miscarriages. In IVF, there are a lot of biochemical miscarriages, especially in natural cycles, that patients are not aware of. I mean, we have sometimes patients who explain us that they have twice or 3 times they've had a cycle longer than usual, in which they felt rare, strange, and then they had the period was slightly later than usual, 3, 4, 5 days, and they have a heavier bleeding than usual. These are biochemical miscarriages that are very difficult to identify in natural cycles. In IVF, yes, it's much more easy because we know when the patient has got pregnant. So sometimes we have very low betas, 20, 25, that go up for a few days and then go down, and these are the kind of biochemical miscarriages. Then we have the blight ovum, an embryo pregnancy, the empty sac. There are different names, which are those pregnancies in which we can see the sac inside of the uterus, but no evidence of embryo. Okay, these are mostly due to chromosomical abnormalities. Okay, and then we have the clinical miscarriages, in which we identify the embryo. We can sometimes even see that there has a heart beating, and a couple of weeks later the patient comes, the embryo is not there, she has started bleeding, or we can still see the embryo but with no heartbeat. In these cases, the reasons could be, I would say, 50% due to the embryo. Okay, either anatomical abnormalities like cardiac problems or things like that, or chromosomical abnormalities, and the other half are due to issues with the implantation, thrombophilias, and antiphospholipid syndrome. So I'm not sure if miscarriage could be included in the biochemical and the empty or blind ovum miscarriages. There was a heartbeat, then it would be a clinical miscarriage. Which means that there could be problems in the development of the embryo, either, as I said, coagulation problems that make the embryo, or that cause a lack of nutrients or the supply of the blood, and then the embryo can stop the development. 16, this is not a miscarriage. Well, yeah, up to 20 can be considered a miscarriage. If the fetus, because at this stage we should talk about fetus, was tested and was anatomically normal, this could either be due to an antiphospholipid syndrome, okay, so kind of a condition. It could be due to placental issues that are not related to any kind of immunological condition, okay, or sometimes it's what we call white, well, I don't know how to translate it to English, I don't know the word. We say white death. Means cases in which the embryo or the fetus die, as it can happen with a newborn baby, that they have a sudden death. The sudden death that happens, it could usually after the baby is born. It can also happen inside the womb. So if you have at 16 weeks, they usually do genetic testing of the fetus, which is what I would initially recommend. They also do a necropsy, so they are able to check if anatomically the fetus is normal, and if both tests are normal, then you would have to consider antiphospholipid syndrome or an unexplained fetal death, which is something that can happen.
Okay, thank you so much once again for explaining that. Okay, next question is right here. I'm diagnosed with implantation failure. I am 35 and have endometriosis. I had ICSI and PGD. I have achieved a biochemical pregnancy, many negative transfers, and a natural biochemical pregnancy. What happens to me? They took hydrosalpinx from me.
From me. Well, it's a quite difficult condition because you had PGS. I would like to know, well, here, of course, I would like to know how did you respond to the IVF, if you produce, if your ovarian reserve was normal or not, how many embryos were tested, how many of these embryos were normal, okay? And then based on that, because in most of the implantation failures are due to abnormalities in the embryos, okay? So, and the hydrosampics sometimes play a role. The hydrosampics are these small amounts of fluid that are inside of the tubes, 5 normal embryos, and lack of implantation. One of the things that sometimes we recommend in these cases is adding aspirin and heparin, as I have explained before, starting the aspirin 4 weeks before the embryo transfer. probably you have also had some frozen embryo transfers. So changing, if you were using, they took it before, so it didn't play any role. Okay, well, not necessarily. There is now one interesting test, but aspirin. But did you start it time enough before you had the embryo transfer? That's the question, because as I've said, sometimes they start the aspirin on the day of the embryo transfer or when the patient is pregnant, and then it's completely useless. You need to start the aspirin 4 weeks before the embryo transfer to have the all frozen. Yeah, because if you had PGS, obviously the embryos had mass 1 week before. That's not really too much, but I wouldn't say that could be the problem. One thing that could be interesting in your case is that because of the hydrosalpinx, sometimes there is a problem that has to do with the endometrium. It could be either chronic asymptomatic endometritis, which is an infection that is not going to cause you any pain, any sore, any issues, any discharge, any fever, but is there causing an excessive inflammation in the uterus. Or sometimes there could be an abnormal microbiome, which means that inside of the endometrium, there should be a different percentage of bacteria. But as it happens in the vagina, there should be more than 90% of lactobacilli. And when there has been I had before endometritis. Okay, so the thing is that the diagnosis of the endometritis is very subjective when it is done in a hysteroscopy. You can see that it's a bit more hypervascularized, that there is a big redness because of the vascularization. But the only way of discarding that there is a bacteria there that can cause any problem is doing an endometrium biopsy and checking. And we have two tests. One is called EMMA. The other one is called ALICE. And the ALICE checks if there is any small amount of the DNA of bacteria, which is very, very accurate diagnosing endometritis. And the EMMA checks that the percentage of the bacteria, the percentile of normal bacteria is correct one. And sometimes when there has been endometritis, you may have had a treatment. Most of the endometritis sometimes are diagnosed by endometrium cultures. Oh, you've already got them. As you can see, it's really difficult because sometimes, if I had all the information, I would have had a shorter response. You got pregnant. The transfers, they don't repeat the test. No, I mean, if they were normal, there is no need to repeat them. Okay, we only need to repeat EMMA and ALICE when they are abnormal. The ALICE is usually treated by giving you an antibiotic. But if you had a positive ALICE, we recommend doing another biopsy to confirm that the bacteria is no longer there, because sometimes bacteria may be resistant to the antibiotics. So it's worth doing another biopsy to confirm that the bacteria is gone. And if the IMMA is abnormal, then we recommend vaginal probiotics to restore the normal population of bacteria. And it is not usually needed to redo a biopsy, because in these cases, the second biopsies have confirmed that in more than 95% of cases, the flora is normal. The only thing that I would suggest in your case then, and it may surprise you, it would be checking the sperm. And the reason is that the DNA of the sperm, okay, there are some studies that has suggested that it's very active at the surface of the placenta. Okay, so the sperm may play a relevant role in the implantation. And I've got cases in which we have been able to demonstrate that there was a genetic problem in the sperm, that we have done PGS to choose the genetically normal embryos, and the patients have not got pregnant. I have a very spectacular case in which we demonstrated that there was a genetic problem in the sperm. The couple decided to try with the man's sperm and went through PGS. They did 8 egg donation cycles. That means 8 donors. We transferred 25 euploid blastocysts, and we only had 2 biochemical miscarriages. At that stage, we were so desperate that we were considering surrogacy. Okay. Uh, well, doble cadena, I'm not sure if it's not that. Well, the 2 things, I'm going to explain you one thing about a fish, because sometimes fish may not be enough. The thing is that if somehow we can demonstrate that there's something wrong on the sperm, okay, as I've said, we transferred 24 or 25 euploid blastocysts, and we only had 2 biochemical pregnancies. So we were discussing with a doctor, because he was a patient from UK, and the doctor was recommending surrogacy. And because the abnormal genetic the genetic problem of the sperm, we recommended a double donation, so changing the egg and the sperm, because she already was an egg donation, and see what happens. It was much easier to do a double donation than to consider surrogacy. So they eventually decided to do a double donation. We had 5 or 6 blastocysts. We transferred 2 because after the number of attempts, they wanted to make sure that they had the highest chances. She got pregnant of twins, and she had 2 babies. So in the end, this is a cycle that, in my opinion, confirms that sometimes when you check the sperm and you have an abnormal genetic or abnormal problem, it's like an iceberg. You see what is outside the water, but you cannot see everything in below. And in this case, we did exactly what was supposed to do. There was a genetic problem. We did a lot of PGS, no results. We changed the sperm, and she got pregnant at the first transfer with twins, and now they are 3 years old. So that's what sometimes is worth to do, some kind of genetic testing on the sperm, despite transferring genetically normal embryos. Because if there is anything abnormal, probably you would have to consider changing the sperm. And with regards to the fish is a test that only checks 3 chromosomes. It has a good sensitivity. That means that when we have an abnormal fish, we know 93% sure, we are now 93% sure that the sperm is normal or not. But there is a 7% of cases in which the fish can be normal, and there could still be genetic problems in the semen. And in these cases is when it's worth doing a meiotic study. The meiotic study is much more sensitive, much more specific than the fish. The fish only checks the sperm. The meiotic study checks the different phases of the meiosis and how the sperm divides. So it basically let us see how all the chromosomes behave, and also if there is some kind of problem in the middle and that is not evident in the final product, in the sperm, it can also be detected. So in these cases, it could be worth to at least make sure that there's nothing wrong on the sperm side.
Okay, excellent. Thank you so much for all your recommendations and advice. Next question is right here. So, do you not believe in lymphocyte immunization therapy?
No. And this is a test that is now forbidden here in Spain. It's a recommendation of the Fertility Spanish Society, because we have had some cases of severe reaction against that, because you are exposed to kind of a transplant. You are exposed to lymphocytes of your partner to make sure if you mean this, because according to what I say, a lymphocyte immunization therapy is that you are given lymphocytes from your partner in order to acquire kind of a tolerance of that, So if this is what you mean, the treatment is now contraindicated and is not recommended or allowed in Spain because of the risks involved when it is used.
Okay, thank you. again for that. Okay, and so what is the experience about polymorphism in the karyotype?
Well, one of the main limitations of the PGS is that we have a very limited amount of cells to study. When we do PGS in the karyotype, in the blastocyst, we get between 3 and 5 cells. So there is kind of mosaicisms or polymorphisms or things that you, because I'm not sure if I'm understanding. One thing is if you mean by polymorphism that there are some kind of abnormalities that are considered to be normal, like chromosome 9 inversions or something like that, that are that the karyotype is not normal, but there is no known clinical problem that comes from that abnormality. Okay, that's one thing. Another thing is the mosaicisms or the polymorphisms. That means that the number of cells affected by the genetical abnormality, the percentage is very low. And I've seen patients with a complete Down syndrome in which only 5% of the cells were affected by the trisomy. The trisomy does not affect, not necessarily affects the whole cells, and if the mosaicism is very low, okay, it could be difficult to detect by the PGS because of the amount of cells that we can study. So if you have mosaicisms or polymorphisms that only affect 5-10% of the cells of the embryo, you may get 3, 4, 5 cells, and all can be normal, but the embryo may still have a problem. So this is one of the limitations that we have with the PGS. This is why when we have these kind of abnormalities in the karyotype, we have to be very careful and inform a lot the patients just to make sure that we detect that in the embryos. I don't know if I've answered your question.
Okay, thank you so much. Nope, no, the patient did not get back to us, so I believe so. But if you would
Okay.
like to ask anything else, just go ahead and type it in, of course. All right, we have like two parts of the question, okay? So it's a bit of a longer story, so let's have a
Mm-hmm.
look at it. I am 48 and had 6 egg donor transfers, 3 different donors, all implantation failure except last one biochemical pregnancy. I had natural pregnancy at 44 with same partner. I had thrombophilia, HSG, fish for sperm, karyotype, ERA, hysteroscopy, all normal. Also tried intralipid, prednisolone in some cycles. I'm currently prescribed levothyroxine to prepare for next transfer. It was suggested natural cycle, but periods are now irregular since
Regular.
had hysteroscopy in
Mm-hmm.
November. Is there any options? And just to add, okay, so, what is the ideal TSH level to help with implantation? I have been prescribed, yes, as before, yeah, due to 6 failed egg donors.
As I've said, TSH ideally should be below 2.5. As long as the TSH is below 2.5, is okay. There is now kind of uh, groups in America that, according to new studies, are suggesting that we can go back to the standard level of 4, but still controversial. So since it's very easy to correct that, we are happy to keep levels between 2.5 until we have more evidence that we can go back to the standard levels of 4. Okay. Wow. Yeah, I mean, in your case, probably, according to the results, the test that you mentioned, you have two different things that you can try. Okay. One is I've seen that you've had the ERA done, which is the endometrium receptivity assay to detect the window of implantation. I don't know if you've had EMMA analysis, okay, because these tests are quite new, and I've found them very useful. They have been no EMMA, okay, so miscarriage 2 weeks. Well, exactly. Probably this was a miscarriage due to your genetic problems because, between 8 and 10 weeks is when they are usually due to genetic problems. Okay. So, the first thing is that I would really recommend checking EMMA analysis to discard any kind of chronic inflammation. I've got cases of young girls, but young girls mean girls that had IVF being younger than 35. So that could be, these girls could be considered as if they were egg donors. That after several transfers and successful transfers, We have done the EMMA analysis. There were really important abnormalities that we have corrected. And after that, at the first transfer, they have got pregnant. So these two tests sounds really very promising to me as tests that are going to explain a lot of unexplained implantation failures. And the other thing, as I've said, I mean, you had the fish done on the sperm. I don't think that it's necessary to do a DNA fragmentation. The DNA fragmentation is usually relevant when the quality of the eggs is not that good, because the eggs have to fix the problems with the DNA. But when you're working with egg donors, as I've said, you can have but luck with one of them, but not with all of them. So probably you've had plenty of really good eggs that if there was any kind of DNA fragmentation issue, they have been able to manage that. But as I've said before, the fish only has a 93% sensibility. So, well, your case is one of those that I would recommend doing a meiotic study to see if your husband is within that 7% of cases in which the fish is normal, but there are genetic problems that cannot be detected by the fish. So, as I've said, consider doing more tests on the male side, and consider EMMA analysis as a way to discard inflammations that may be impairing the normal implantation.
Okay, all right. Thank you so much for that. And when we are at it, can you just add what is EMMA analysis?
EMMA is that we now have a test, okay, that is called that are tests in which we perform an endometrium biopsy, and then rather than the standard histopathologic study that has been done for many years and that we now know that is not relevant in terms of fertility. It is useful to detect other problems like hyperplasias or cancers or things like that. But in terms of fertility, the standard biopsy that has been done for many years is useless. But with this biopsy, we can do 3 different tests, and they can be done with the same biopsy, okay? Which is a biopsy that is usually done in the second phase of their cycle, or if it is done when the patient is taking hormones, it should be done once the progesterone has been started, okay? And if you want to do one of them, it has to be done on the same day that the transfer should have taken place. Okay, but as I was saying, we have 3 different tests. The ERA stands for endometrium receptivity assay, and it's a test that confirms that that is supposed to confirm that the endometrium is receptive, that when you are transferring the embryo, the endometrium is going to be ready to accept it. My confidence on this test is not that much. In fact, we are now collaborating with the laboratory to review the newer cases that we've had, because when we started doing ERA, the results were not that good, but they have changed the technology and they have added a lot of information, and we are now reassessing if ERA is improving our results, but so far we don't recommend ERA. And then we have the EMMA with double M and the ALICE. Okay, the EMMA checks if the microbiome is normal. The microbiome is the standard flora, the standard group of bacteria that should be in the endometrium. There is a microbiome in the endometrium, in the vagina, in the bowels, in the lung, okay, in the skin. So we, I don't know if you're aware of that, but we all, and a normal person has 2 kilograms of their body are bacteria. Okay, 2 kilograms that are distributed, and these bacteria are essential for our health. In the endometrium, there are also bacteria. 90% should be Lactobacillus crispatum. Okay, so the EMMA basically checks if these levels of lactobacilli are balanced or not. Why? Because the lactobacilli protect against infections. If these lactobacilli, because of any reason, are low, this space okay, is going to be occupied by bacteria. So we need to have a good level lactobacillus to avoid that pathogen bacteria may grow. And then we have the ALICE. The ALICE is the test that detects the DNA of many bacteria. Some of them can only be detected if we do the ALICE because they don't grow in the standard culture media that we have. Okay, so endometrium culture can sometimes be useful, but there are a significant percentage of bacteria that are not going to grow. So the only way in which we can detect them is by detecting the DNA doing the ALICE.
There's a follow-up question.
As long there is any kind of implantation problem, yes, but you cannot do it on the same cycle because you are going to do a biopsy, so you are going to destroy the endometrium. So you usually do it in a cycle in which you are not stimulated, okay, and usually in the second phase because the microbiome is different from between the first phase of the cycle and the second phase of the cycle, and then it should be done between in assuming that someone
There's
yeah, yeah,
another one.
yeah. In fact, the laboratory has a test called endometrio, the trium, the three, which includes ERA, EMMA, analysis. And then you can do the ERA. Yeah, no, it's up to you. I mean, they claim that once you have an abnormal ERA, the results, once you fix it, the results are going to be the same 2 months after the biopsy or 2 years after the biopsy. So no problem. And if you do the EMMA and the ALICE, well, sometimes it's quite hard to get rid of the infection, and you need to do more than one course of antibiotics. I mean, I've got patients that have to go through up to 4 biopsies until we have managed to clean the endometrium and restore the normal microbiome. So sometimes it's really, really hard because the endometrium is a very difficult, very poor vascularized structure. So you need to use doses of high doses, long treatment, and sometimes the bacteria may be resistant to the antibiotic. So I've got cases in which we have done the biopsy, we've got an abnormal result, they have gone through a treatment, we have repeated the biopsy, there was the same or another bacteria because the lactobacilli were not good enough. We have gone to go through different biopsies until we have got the normal results. And the results in these cases are very, very good because these kind of abnormalities are important enough to explain the whole case, the whole number of failures and problems.
All right, perfect. Thank you so much again. We will be slowly finishing. Of course, there are some questions left, so we have some time. We can still go ahead with them. If there are any questions that will not be answered, what we do, we will simply send it to Dr. Raul and his team,
Yeah,
and I'm
pleasure.
sure they will be able to get back to you.
Absolutely.
But we can still have some more questions, right, Dr. Raul?
Yeah.
Okay, perfect. So next one is right here. So what vitamins or supplements would you recommend in early pregnancy to prevent miscarriage?
I mean, the only vitamins, the only substance that has proved in some studies to improve this is the folic acid. And there are some studies that suggest that instead of the standard dose of 400 milligrams, taking 800 milligrams, so 2 pills a day, could reduce the miscarriage rate. Any other antioxidants, vitamins, so far there is no evidence that any of them could help the embryo become genetically normal or implant in a better way or get rid of any coagulation or immunological problem. So if we just accept that so far there is no evidence that any substance can improve the quality of the eggs or can improve the genetics of the sperm, except in very specific cases of DNA fragmentation. As a standard routine, I wouldn't recommend any specific treatment in a patient with a recurrent pregnancy loss.
Okay, thank you once again for that. And now let's go to the next question. It is a longer one, so let's have a look. I am 35 and I have had 3 miscarriages within the first 8 weeks of pregnancy, 4 years of trying to receive 1 natural, 1 with IUI, 1 with IVF. My genetics say that I have an inversion on chromosome 9, P12Q13. In Germany, PID is not allowed, so I am treated in the normal IVF cycle, but I fear that this will happen very often due to genetics. What do you recommend?
Yes, I would recommend PGS. I mean, the inversion on chromosome 9 is one of these kind of things that sometimes is considered to be normal with no genetic problem. But when we face, I mean, probably in your case, what I would suggest is to, as I've said, first check the genetics of the sperm. Okay, because if there is something wrong in your karyotype and something wrong in the fish, then probably adding the two different factors is going to make very difficult to obtain genetically normal embryos. So, and then if you have an inversion of the chromosome 9, yes, I would suggest PGS in most cases of the recurrent miscarriages, because this is the only way of being sure that the embryos are genetically normal. And as I've said at the very beginning, genetics are usually the main reason or the main factor or the most important factor to have a miscarriage. So it's very important to know the information that we have from the embryos. If we test, let's say, 6 embryos and 5 are abnormal, this is going to be very important to consider that probably the genetics are playing a very relevant role in the miscarriages. If we do PGS in 7 embryos and 6 are normal, well, then you better focus on other things. It's true that, and I've seen cases in which PGS can be very different from cycle to cycle, but to me, in cases of recurrent pregnancy loss, it's very important to be sure that we are transferring genetically normal embryos. And once we have those genetically normal embryos, then since they are going to be frozen, we may have time to check other factors and to be sure that whenever we transfer them, the environment is the best that we can get. But yes, probably I would suggest you PGS, even if your karyotype had been normal.
Okay, thank you once again for that answer. Okay, and there's a follow-up. Is fish possible in Germany? Whether you know?
I don't think so.
Okay. Mm-hmm.
It is as I've said, that there is no people is not really aware of the role of the main factor. I mean, they are now doing more and more DNA fragmentation. But DNA fragmentation, it is also very controversial, because there are people that say that when you do ICSI or when you work with really good young or good eggs, that the DNA fragmentation is not relevant in terms of, and we now have technology like IMSI to deal with those fragmented sperm. But the fish is not considered, the fish or any other genetic study, like I've said, meiotic studies to check the genetics of the sperm is not something that first, that is not available in many countries, and even in those countries that is available, it's like, it seems that if you have a normal karyotype, a normal spermiogram, just forget about the sperm. So no, I'm afraid that you would have to come to Spain, or because as long as I know, there are only very, very few places in Europe that can be done. I don't know if any Spanish laboratory may have an office in Germany. I don't think so. I know that there are Spanish laboratories that have offices in Italy, in France, in UK, and now we are available to do fish in those countries, at least in big cities, because they are working there, not because there are local laboratories doing that. But I'm not sure about Germany.
Okay, so thank you so much for this. And there's another question. There are like 2 of them about TSH levels. You have mentioned this, but if you could take a look, as they are very similar.
No. Once more, I mean, TSH should be below 2.5.
Below 2.5.
Below 2.5. No, no.
Okay.
Once one is below 2.5, there is no evidence that being 2, 1.5, 1 indetectable does not change the outcome. And even, as I've said before, nowadays, there are groups that consider that between 2.5 and 4, that the outcomes are going to be very similar. But these are very early studies, and we prefer to keep the 2.5 level. But once it's below 2.5, no differences.
Okay. Excellent. Thank you again for confirming that. Another one is right here. I had preeclampsia in 7th month after egg donation. I'm in 45 plus. What
Hmm.
medication test would you recommend for next attempt?
Well, one of the things that has now, I mean, one of the things that has been suggested in these cases, okay, is that the HRT, the hormone replacement therapy that is usually used during egg donation, could increase the risk of preeclampsia. Okay, it is not really well known why, but the big studies, I mean, the big studies that we get from the countries when they have the national registries in which there are thousands of people, you know, have suggested that in cases in which there is a history of preeclampsia, one of the best things that you can do, if it is possible, of course, is to work with the natural cycle to transfer the frozen embryos. And in cases in which you are working with fresh eggs, because you know that egg donation in some countries is done with frozen eggs, we do not recommend that. We always work with fresh eggs. And we need to use hormones to synchronize the cycle between the donor and the recipient. In these cases, when there has been a preeclampsia, what we recommend is a segmented cycle. That we obtain the eggs, we create the embryos, we freeze them, and then we transfer them in natural cycles, okay? Whenever it's possible, because obviously if the woman is menopausal, there is no other way and you would have to use. And then what we try to work is with the lower doses of estrogens. Then you would have to consider working with very low doses of estrogen, okay? Try with 4 milligrams and see with 4 milligrams you have a good thickness, work. In these cases, what we recommend is a kind of a dummy cycle in which we work with different amounts of drugs just to see which is the lowest dose that allow us to get the right thickness.
All right, perfect. Thank you once again for explaining that. There's a short question right here as well. How do you treat thrombophilia?
Aspirin and heparin.
Mm-hmm.
Because they are usually work better combined because they have effects at the different levels of the chain of the coagulation. So thrombophilias, usually we recommend taking both. Aspirin, we use a doses of 100. It could be sometimes 75 or 125, depending on the country, but around 100. And the Clexane, as I've said, a standard dose of 40 milligrams.
Okay, perfect. Thank you once again for that. Let me just have a look. I believe we will have one more option for a question. It's right here, quite a long one, but I hope you will be able to. We will be able to do it. Yeah. I had a biopsy during hysteroscopy. It showed some kind of inflammation. This inflammation was not recognizable during the hysteroscopy, looking at the endometrium through the camera, but the sample test showed something. I was given antibiotics. 2 months later, I got pregnant with my own embryo transfer, but the pregnancy stopped developing in 7th week was the SEMA. It was 5 years ago. Later, the doctor told me they do not do this analysis anymore as it is not relevant for the implantation. I was told the endometrium is not tested like this anymore and that doxycycline, is not given before.
Doxycycline, yeah.
Yes, thank you.
Yeah.
Before it was even given just in case in a cycle before, but without the biopsy.
No, it was not EMA because EMA is available since 2 years ago. Okay, so this is not an EMA. What you had, I mean, as I've said before, the way the endometritis was diagnosed before the EMA era, okay, when we had, before we had IMA available, was either because during the hysteroscopy, they were saying that there was a very vascularized endometrium, very red with a lot of vessels, suggesting that there was kind of inflammation, or in some cases they were taking samples that were put on an endometrium culture, as when you, for example, has an urine infection and you have your urine culture. There was the similar thing, but done with the endometrium. In some cases, it was positive, as I've said, and then we used to give antibiotics. Doxycycline is still used. It's not contraindicated, and it is a drug that is very useful against chlamydia, mycoplasmas, ureaplasmas, and things like that. So it's still used and quite often. Okay. But this was the only techniques that we had: endometrium culture and the subjective image, with that, depending on the experience of the doctor that was doing the hysteroscopy, was more accurate or worse accurate. Now we have the EMMA. So probably if you had that problem, it could be something. I don't think that this is related with your miscarriage, because EMMA, as far as we know, are related with implantation, not with miscarriages. Okay, so I don't think that this is something. Probably you had the miscarriage because any other factor. But if you've had treatments and you've not got pregnant, or if you're planning to have more treatments, EMMA could be a good option. EMMA ALICE, because the EMMA checks the microbiome. ALICE is the one who checks the bacteria. To do one, just to make sure that what you had a few years ago has now gone. This kind of endometritis can last for many years silently there, without giving any kind of symptoms or signs, but they could affect the endometrium for years and years.
Okay, perfect. Thank you so much for yet another question and your help with it. Okay, and just one additional information from the patient: miscarriage was because the embryo was not
Yeah.
healthy. Mm-hmm.
No.
Okay.
Exactly. So I don't think that what you had has any kind of relation, or could have somehow related to the miscarriage. There was another factor. Things are different.
Okay, understood. Perfect. Thank you again so much. Now it will be our last question for today, okay? But don't worry, all the questions that haven't been answered, I will definitely forward those to the team and Dr. Raul, and I'm sure they will definitely get back to you, okay? And the last question is up right here. So just give me a second. It was before, so let me put it here.
I
Yeah,
was
the last
surprised.
topic that I
I
missed.
was surprised nobody was going to ask about this.
Okay, so here it is for the end.
Yeah. Well, this is very controversial. Okay, so I'm going to try to explain it, because it's sometimes probably one of the most difficult things to understand, or to translate to understandable words. Okay, the KIRs are killer inherited receptors. So these are receptors that are on the surface of the natural killers. Okay, the HLA are histocompatibility antigens. So these are antigens that are shown in the placenta and are responsible, in some cases, some of them, in the fact that you can reject a transplant. Okay, so the HLA belong to the embryo. The KIRs, the receptors, belong to the mother. And then there are an interaction at the implantation between the HLA and the KIRs. Okay, there are two different profiles of KIRs. We have what we call the haplotype A and the haplotype B. The haplotype A is when the patient is AA. That means that he has inherited one A from the mother and one A from the father. So the woman is AA. That means that she has an haplotype A. And if the KIRs are AB or BB, we call it haplotype B. The HLA could be C1 or C2. And again, in this case, we have C2, but the man or the woman can be C1 or C1, C2, depending on what has inherited by the parents. So it has been it is well known that in places where the women are AA, there are very few embryos C2 because this relationship is not good. And in cases in which there are a lot of patients that are B, has a KIR B, the most common are C2 because there is a correlation between a bad relationship with the C1s. So the theory nowadays is that in cases in which the embryo shows, because the embryo is going to get one HLA-C from the father and one HLA-C from the mother. It could be either C1 or C2. So we can have embryos that are C1, embryos that could be C2, or C2, depending on the HLAs that the fathers have, that the parents have, okay? When the embryo has more C2 than the woman, okay? It's very, very difficult. I'm not used to explain it without drawing because it's very difficult to understand. So when the woman is C1 or C1, C2, if the embryo has more C2 and if this C2 come from the man, okay, there is a kind of a bad reaction, okay? And this is also becoming relevant in egg donation, because if the embryo has more C2 than the woman, but this C2 come one from the man and one from the donor, so we are not, the woman is not dealing with the own C2, so she's dealing with two C2s, that one comes from the man and one comes from the donor, the reaction can be even worse, okay? So when the woman is haplotype A and the embryo has more C2s than her, then there could be a problem, okay? The thing is that there is one study carried out in the United States in which they check, because initially it was suggested that the problem was only between haplotype A, because it's called the inhibitory profile, and C2. But in this study that was done checking the real HLA that the embryos had, they showed that it was bad haplotype A and C2, or haplotype B and HLA C1. So that these kind of problems were correlated. Okay, I hope you understand what I'm saying.
All right.
So the thing is that if there is anything else, anything that we can do, there has been suggested some drugs that are not approved for these treatments, drugs that are supposed to regulate this. So far, there is one study that suggested, of course, in countries in which PGS can be done, we would be able to choose those embryos that have equal of lower C2 than the mother and transfer them before, okay? The thing is that what we are now recommending is that this abnormality, this problem of a higher miscarriage rate seems to take place only when we are transferring more than one embryo, okay? Because then the amount of C2s that the woman has to deal with is really high. But when you transfer just one embryo, this kind of higher risk of miscarriage is not so evident. So when there is this incompatibility, when the woman is haplotype A and the men or the donor are C2, or we think that there could be high chances that the embryo can have more C2 than the woman, what we are recommending is elective single embryo transfer. And there is a study carried out by a Spanish group that confirm that if an elective single embryo transfer was done, the miscarriage rate was absolutely normal. Okay, so but this is a very new. We are still gathering data. I've read 3 different theories, and so far no one has proved to be the definitive one. So there might be. So we are still learning. It could be relevant, and we may have ways of selecting the embryos and choosing the right combination. But so far is very, very controversial.
All right, perfect. Thank you so much. As I
The most
mentioned,
difficult question was the last one.
yes, but definitely interesting as well, of course. So, well, huge thanks for all those questions, for joining our event, Dr. Raul. It's your second webinar with us, and it has always been wonderful, very detailed answers. So, huge thanks for that. I am
You're
sure
welcome.
it is very, very useful. And again, I am sorry we are not able to finish with all of your questions, but do not worry. As I've mentioned, I will definitely forward those to Dr. Raul. So
Yeah.
yes, I agree. We must repeat it. I totally agree. So as you
You're
can see,
welcome.
only nice comments right here.
Thank you.
So again, huge thanks for joining us, and huge thank you for all the help you have provided already.
Well,
Okay, see, so it works.
perfect.
Perfect. Okay, as you
I
know,
commit to answer all the questions, all the remaining questions.
yes, happy to hear that. I will definitely do it. Okay, and see, first time Kier HA topic was explained so good. So very, very nice. Happy
Wow,
to
that's the best compliment I can have.
perfect. Thank you. It's definitely okay. There's another one I need to show you. See you as soon as borders open. So thank you so much for so many nice comments, and we are very happy that you are satisfied and you've got some answers. I do know that you did. So thank you. I hope you will be able to join us. Like in 10 minutes, we will be having another webinar. We will be connecting with Carmen Martinez. She's located in Mexico, and well, it's another topic. She is a writer as well on the egg donation and how go through it emotionally, so it might be also a good opportunity for you to take part in. And well, again, huge thank you. Have a lovely
You're
evening,
welcome.
Dr. Raul. I mean,
Yes.
let's just repeat it, nothing else to
Yeah.
say, really.
No problem. No problem. If I'm always willing to help and share the knowledge. That's really nice.
Perfect. Thank you once again, and take care. Bye.
Take care. Stay safe. Bye bye.